Starting. All right. Okay, cool. I'm trying to record on my laptop as we go for people that aren't here. Okay, so pericarditis, it's an R2 condition. I don't think it should be an R2. Thank you. I don't think it should be an R2 condition because it seems to come up a lot. And so the picture on the left is pericarditis. So essentially it's the inflammation of the pericardial sac, and the pericardial sac is kind of like two layers of, kind of like the pleura, you know, the lungs have like two layers. The heart also has two layers. It's an inflammation of those layers. Can anyone tell me, just for fun, why I've put this picture here?
Comfortable lean forward?
Yeah, it's more comfortable lean forward. Okay, so these are your risk factors. So males just tend to get the blunt end of the stick. They just don't do very well. And we find that in peds as well. So risk factors, 20 to 50 years old, any sort of infection, history of metastatic neoplastic disease, and any cardiac surgery. Okay, so the stuff I've highlighted in yellow are like the important stuff because there's a lot of stuff that can cause it, but this is the stuff that you kind of have to know. So it can be idiopathic. I think someone today in peds had pericarditis. Oh yeah, you were telling me that in ED, someone had pericarditis as a kid, and like, what the hell?
No, sorry, that was infective endocarditis.
Oh, okay. But you told me it was pericarditis.
What a roller coaster.
That was another.
Whatever. The point is, you can get it as a kid as well. So viral is the main one, or one of the main ones. Coxsackie B virus is, there's nothing else that Coxsackie B virus causes, right?
Hand, foot, and mouth.
There you go. Okay, proving me wrong, left, right, and centre. EBV, influenza, and something called echovirus, whatever that is. Bacterial, fungal, always has to be in there as well. Metabolic, any sort of uremia, because obviously that can make your blood really inflammation prone and not fun to be mixing together. Autoimmune stuff as well, because that can just cause inflammation like all over the body, wherever. Rheumatic heart disease, same thing. Any malignancy. TB, you just kind of have to chuck TB in there. And post-MI, Dressler syndrome. So Alex touched on this last week. Does anyone remember what Dressler syndrome is? You briefly said it last week. Does anyone remember? Yeah, pretty much. It's pretty much it. Yeah. So the way I remember it is if your heart has a heart attack, you know how like when you get sick and you have sort of an affront on your health, you just kind of feel shit for a little while afterwards. That's what I kind of think of it as. You know, you've had this affront, you've had this MI, and then your heart still kind of is inflamed. Okay. So pathophys-wise, so the inflammation of the pericardium, they rub against each other in the heart, and this causes pain. So obviously you can see that this outer layer, or this inner layer is right against the heart, and then it's got some fluid in the middle, so that's kind of like lubricant, and the outer layer as well. So these guys become inflamed, like down here. So you can imagine if that's rubbing against the heart, that's where you're getting chest pain from. And it's an acute thing, so it's less than 6 weeks. So if it's a longer term chest pain thing, you'd be thinking more of an angina kind of picture. Okay, so clinical features, we already touched on pleuritic retroesternal chest pain. So it improves on leaning forward, and we kind of talked about that a couple of weeks ago. If you think about the heart kind of just hanging there in the chest, kind of gross. If you're leaning backwards, it's leaning against all the other structures, whereas if it's leaning forward, there's kind of like it comes away from the lungs, so it's not leaning against the lungs, so it feels a bit better. Does anyone know why it's pleuritic? Like physiologically, why is the pain worse on inspiration? Yeah, exactly, because the lungs expand when you breathe in, and that's pushing against the pleura and pushing against the heart, that causes pain. So you're probably going to have a history, recent infection, and also some shortness of breath, because if it hurts to breathe, you might not be breathing properly, so you're going to be short of breath. Examination, you've got a friction rub on auscultation. I've included a YouTube video there that you can just listen to on repeat. Pulsus paradoxus, so your BP decreases by more than 10 milligrams of mercury on inspiration, and I'm not actually sure why that happens. Does anyone know why that happens? Because it's the pulsus paradoxus. I just chucked it in there because it was on last year's slides, and I didn't understand then. I don't understand it now. Don't need to know it. So you could have a pericardial effusion. Does anyone know what you would hear with a pericardial effusion on auscultation? Muffled heart sounds. Yeah, you're getting there. Muffled heart sounds. Yeah, because if you've got a sac of fluid, I'll get there because I do tamponade. If you get a sac of fluid around the heart, obviously you can't hear as well. Tachycardia and signs of right heart failure in constrictive pericarditis, because that's another kind of pericarditis. So that heart isn't able to pump as well, so then you're getting some right heart failure signs. Okay, ECG, this is really an easy one because it's diagnostic. So you get global ST elevation because there's a lack of oxygen globally. So again, I think Alex or maybe Maddie touched on this last week or whenever we did ECGs, this is a really easy trap that people can fall into if you don't look at all the different leads when you're assessing an ECG, especially in an OSCE situation. If you just look at V1, you're like, oh my God, oh, there's ST elevation in V1, it must be this. But you don't check it all, it's actually pericarditis. Okay, so this is the ECG. So you can see, like I said, if you just kind of look at V1 or even lead 1 or any of the leads and go, oh my God, ST elevation, it's this. But you've got to check all of them. And you can see in all of them, except these guys, because that doesn't count. Okay. So that's like your pathognomonic thing, global ST elevation. In terms of investigations, bloods, FB, UEC, LFTs, chuck them in there. CRP, ESRs are our inflammatory markers. Does everyone know what ESR is? Cool. Troponins, robots. Troponins to rule out a heart attack. Viral serology just to check for etiology, and blood cultures again to see if it's bacterial. Imaging, chest X-ray, and cardiomegaly if effusion is present, which again I will talk about.
Sorry. Oh,
yeah.
Yes. Okay.
With ESR, what does that actually mean?
So it's a longer term. It's an inflammatory marker, but it looks like longer term. So CRP is an acute phase inflammatory marker, whereas ESR, it's longer. I'm not actually so sure how it works. Maybe one of you guys does. But essentially, if your ESR is raised, it's more of like a chronic inflammation picture than an acute inflammation picture. Do you guys know what it actually does?
Yeah,
how it actually works?
That's pretty much all you have to know.
Yeah.
Sorry, don't let me look.
Okay.
Sorry, I just one
Yes.
point. Troponins can also rise in pericarditis, so this is something to keep an eye on. And I think something that all you guys should maybe look up is other causes of troponin rises, like apart from an AMI, because there's quite a few that can like mislead.
Yes.
Homework.
Yeah.
Presents back next week.
Yes. Yes.
You mentioned that like it's normally viral in cause.
Yeah.
Which of those investigations helps you like establish?
So the that's not this one. This one. So the viral serology, and again your FBE as well. If you're looking at white cells, you'd be looking at more of a lymphocytic picture than a neutrophil. And if your blood cultures or your CRP is normal, then you'd be looking more viral. But you get that on the history as well. I feel like that's something we're learning this year, how to differentiate like a viral picture and a bacterial picture. Yeah.
It's also usually not really important to know what virus it is because it's not going to change your management. So, yeah, you'll find that most people won't actually go looking for the virus because it doesn't really matter.
Yeah. I feel like that's probably just something to chuck in an OSCE so they know that you know that pericarditis is caused by a virus. Sorry. Okay. Yes, and that's a good point for my recording people. The troponins actually rise in pericarditis as well, so it's not a sensitive, it's specific. Rule it in, but you can't rule it out. Yeah, and you've got some homework. Okay, so in terms of medical treatment, so NSAIDs, obviously anti-inflammatory. PPI is purely in there to prevent GIT bleeding with NSAIDs because you're going to be on NSAIDs for a long period of time. And colchicine just prevents neutrophils from being recruited to the area, so prevents actually dampens down the inflammatory response. And again, treating the underlying cause. If it's bacterial, you can treat that. But again, if it's viral, what are you going to do? It's just kind of, you're treating the symptoms. So if it's bacterial, you would do a pericarditis if there's an effusion, and then get your antibiotics from there. And surgical, you can do a pericarditis to either drain the fluid for symptomatic, or again to get some cultures and stuff. Okay, differentials. I don't know what I was doing with this slide. I don't know why it's blank. Okay. No. What are our differentials for chest pain? I think is what I'm doing. Yeah. Yeah. Yep. Yeah.
Red flag.
Okay, I'll just put it in. Okay. No, this is differentials for like retro. I think it's differentials for pericarditis. I'm sorry, that's my fault. So costochondritis, is kind of one of those things that you don't really want to miss. Well, I mean, you can miss it because it's not like super serious. You're not going to die from having costochondritis. So costochondritis is like an inflammation of the cartilage sort of in your chest here. It's reproducible pain though, so if you push on their chest, it's going to hurt. So I think these are all differentials for like pleuritic or like retrosternal sort of chest pain. MI, not necessarily get pleuritic chest pain, but everything else you kind of would. Does that make sense? Sorry, I made these slides like 3 weeks ago, so I forgot what I did. I actually thought I was presenting last week, if any of you saw me post, and then immediately change it afterwards. Okay. Complications. Cool. So recurrence is kind of a big one. So you can get people that have recurrent pericarditis, and it's not very fun. Effusion tamponade, I'm going to talk about in a sec. And constrictive pericarditis, I kind of touched on before. So that's when you can imagine if your pericardium is really inflamed and kind of all the time, that eventually just kind of fibroses and scars a little bit and then constricts on the heart. And again, that's when you get your right heart failure picture because your heart's not able to beat as much. Okay, does anyone have any questions about pericarditis? Yes.
What's Kussmaul's sign?
That's a really good question. Kussmaul's breathing is different to Kussmaul's sign. He's one of those guys that has like 2 different things with one name. So selfish. It's like Gilbert's disease. I can't name a disease after myself now.
I've got Gilbert. Like I had to say that. I've got a high bilirubin. I have to talk about myself.
Congratulations. So Kussmaul's. So I believe Kussmaul's sign is when you. Oh no, I'm getting confused with AR.
I think you had a
Yeah.
What you said was
On inspiration. Yeah.
plus on inspiration.
Yes. Yeah, we just figured that out. Yeah. So it's JVP rise on inspiration. I don't know why it happens. I don't think it's super important.
Probably related to the blood pressure.
It's just kind of one of those things that you chuck in. It's like when you do aortic regurg, you look for all the quinkies and all the random things, just kind of signs that you look for, but you don't actually know how they work. Any other questions?
Sorry,
Yeah.
I've also never heard of Kussmaul's breathing. Would you be able to explain that to
Yeah,
me?
so Kussmaul's breathing is like the kind of like DKA sort of picture. It's really sort of soft, shallow. I can't really like replicate it for you, so I recommend you go and YouTube it. Yeah, but that's kind of like the pathognomonic kind of thing for DKA. Yeah.
Just very quick, like,
Yeah.
to like blow off all this CO2 because they're acidotic.
Yeah.
Thank you.
Yeah. Okay. Oh, wrong one. Wrong way. Okay, so pericarditis. Oh, no. Oh, I can't go back in this recording, so it's just happening. Okay. Cardiac tamponade. Again, this is an R2 condition. Bless you. Such a cute sneeze. So the difference between pericardial effusion and tamponade. So pericardial effusion is any sort of accumulation of fluid in the pericardial sac. So you can see that picture on the right that it looks like a big balloon. So the fluid, I should clarify, is between the 2 layers of the pericardium. It's not between like the heart and the pericardium. It's like between the 2 layers. And a cardiac tamponade is really just a pericardial effusion that causes decreased cardiac output and shock. So I used to think that cardiac tamponade, like it had to be blood. Like I always just thought it was like blood around the heart, and then effusion was like anything else. But it's actually an effusion that causes poor cardiac output, and that's an emergency because it gets to the stage where the heart just isn't beating properly, and it's not sort of like the constrictive pericarditis where you're getting right heart failure. There's so much pressure on the heart that it's actually just not beating at all. So it's an emergency. And again, something that you don't want to miss in your differentials for things. So risk factors, pretty much the same as pericardial effusion. There's a couple of other things like hypothyroidism for some reason. Obviously, anticoagulation if it is blood that's in there. Aortic dissection, sort of anything, any sort of pericardial injury or like hemorrhage or any of the same risk factors for pericarditis. Because obviously it's a sequelae. Okay, so how can fluid get into there? Because it seems like a closed space. So pericarditis, obviously, we've talked about. Rupture of ventricular wall post-MI, which is one of the complications that I think Alex talked about the other day. So if you've got a rupture of the ventricle, that's a hole that everything can come in. And maybe the tamponade won't be your biggest problem if your ventricle's ruptured, but it's still going to happen. Aortic dissection, if it's really close to the heart, if it's quite proximal, sort of like in the loop there. Anything like hemodialysis, warfarin, transeptal puncture. You can cause, like if you're doing a pericardial centesis for an effusion just to like get some cultures and you accidentally like puncture or something and all of a sudden there's blood in there and it's just not great. Malignant disease again, and any sort of trauma. So I believe it can happen like after CPR if you're doing it really hard. You know how sometimes you can like rupture the heart by doing CPR really hard. That's another thing that can happen. Okay, so pathophys wise. So again, our definition is greater than 100 ml of fluid, which isn't actually a lot of fluid if you think about it. That's causing raised intrapericardial pressure. Because there's so much pressure, the ventricles can't fill as properly because you imagine like the atria working against so much pressure to get the blood into the ventricles, it's just doesn't want to go in there because we know from basic principles that they go to places of less pressure. So you get a fall in cardiac output because you're not pumping the blood as much, and then you go into cardiogenic shock. So too much pressure on the heart can't pump properly. Yeah. So clinical features, so it's still going to be your chest pain, but these guys are going to be in a bit more trouble. So they might be collapsing, they might have some peripheral edema, shortness of breath, confusion, fever, and oliguria. I think that oliguria is just your body's response to like the fluid to try and get it out. Examination, they're going to be tachy. You're going to have Beck's triad, that is pathognomonic for cardiac tamponade. So it's when you've got hypotension, again because your cardiac output has decreased. You've got an increased JVP because your heart is fluid overloaded, and you're going to have muffled heart sounds like we said before because your heart is like literally a further distance away from the chest wall because it's surrounded by fluid. And again, you've got your pulsus paradoxus and your Kussmaul sign. You can also have hepatic congestion because of all the fluid and everywhere. Okay, so ECG, electrical alternans. It's one of those interesting ECG things that it's kind of hard to see in real life. Like this example is kind of easy, but it's hard to like pick up on a real life ECG. At least that's what I think. So electrical alternans is variation in the R wave. So that's our like straight up and down, or like this point here. So you can see this one's down here, this one's over here, this one's down here, and this one's over here. Don't ask me what happens. And again, you've got lower voltage because your heart is beating against it's got so much fluid in there. It can't beat properly, so it's not reaching the same level of electrical activity, and flat T waves as well because your ventricle's not repolarizing. So this is, yeah. Yes. Good segue. Yes, so you would see low voltage in all of the leads. So again, this is potentially something they could give you in an EMQ or even an OSCE situation. Slide you across this ECG across the desk and you're like, oh, what is this? But you can see if you think about what a regular ECG looks like, hopefully you can tell straight away that the voltage is lower a little bit, like it all looks smaller. It looks like it's zoomed out almost. And you can see this electrical alternance happening here and all the way over here and down here as well. Yeah.
Just in the previous ECG,
Yeah.
it said flat skin waves.
Yes.
But they looked flat, not flat.
In this one.
Yeah.
Yeah, so this is this is showing electrical alternans, and then flat T waves. Hopefully you can see in this one. Like this one isn't necessarily a tamponade ECG. It was just sort of an example to show you that one.
Yeah. Thank you.
That's okay. And this one you can kind of see like the T waves are flatter as well.
Yeah.
It's a good pickup though. I didn't think about it. Okay. Investigations. So again, you wanted to do your FBE, UEC, CRP, ESR, troponins, blood cultures, etc. Chest X-ray is diagnostic, or like not diagnostic, but like one of those things. Water bottle sign. I don't know if you guys have heard of it. It's a pericardial effusion. So if you imagine, they call it water bottle because of like the old leather water sacks that they used to carry around in the old days. But I kind of think of it like a water balloon. Like, has everyone filled up a water balloon at a tap? You know how like you let it go and it just kind of like drops down and gets like saggy at the bottom. So that's what that looks like. And again, it's the same principle. You've got so much fluid in the heart that it's literally like dragging the sac down. So you get, and don't do what I did. In a practice OSCE last year, there was a heart failure station and they slid across this a chest X-ray to me. And I was like, oh, it's a water bottle sign. Well, he's got cardiac tamponade. He didn't have cardiac tamponade. He just had cardiomegaly. So don't do that. Learn by my mistakes. So you can tell the difference because this one, I wish I had a picture. I'll get up a picture. I'll do them side by side after I finish all of this and recording because I don't want to get out of it. But yeah, I should have done that because it's more so, oh wait, you can't see if I point. It's all like over here. Do you see how it's all kind of, I don't know, it's kind of like sitting on the diaphragm, whereas cardiomegaly sort of still maintains the shape of the heart. It's just bigger. I don't know. We'll get side by sides up in a second. And echo is gold standard because you can see the collapse of the ventricles. There it is. That's the year water bottle. This one's probably a better one. Like you wouldn't look at that and think it's cardiomegaly necessarily because you can see, well, you can't really see anything. It just looks like a really big kind of sac in there. Yeah.
So you said 100 mils before
Yeah.
For tamponade.
It's greater than 100
More
mils.
than, okay.
Yeah.
So that's like severe.
Yeah, that's probably, I wouldn't want to think how much liquid's on there. So in terms of medical, so like we said, this is a medical emergency. So this is something that we've started, or that you should be starting to do with your OSCEs. If you know that something is a medical emergency and they ask for management, you start with your doctor's ABCD. So you go through and you don't do like any dangers and send for help. You start with ABCD. So you start with their airway, you maintain their airway. Are they breathing okay? If they're not, I would give them oxygen. Then I would, fluid resus and all this kind of thing. So you want to like systematically step your way through it like that. Because there's no other medical management for this one. That's what you do. I should have written it like that. In terms of surgical, so if it's non-acute, they can actually go in and just put little slits in the pericardium to allow slow release of fluid, which makes me feel so uncomfortable because like you just imagine all that fluid like leaking out like a sieve. It's just like into your chest. Oh. Anyway, acute, they can do pericardiocentesis with ultrasound guidance. So they just go in and get a needle and suck it all out.
Do you guys know what the pericardial fenestration is called? You guys on CT surge? It's a pericardial window.
I do that.